Hello, good morning. My name is Robert Detch. I'm the current president of the UCSF Abbott Alumni Society, and I just wanted to start off the morning with a few announcements and then give way to Dr. Ma, who will introduce the meeting. Please sign in at the front for your badge and to get CME credit. There will be an online course evaluation at the end of the conference. On the last page of the online evaluation, it'll ask you to edit the credit hours as a max of 13.25 CME credits for this meeting. And the certificate will be emailed to you after completing the online evaluation. For the speaker evaluation, this is also online. Please see the QR code in the syllabus. We appreciate your feedback. Lunch today will be on the 11th floor. We're on the 10th floor right now, so one floor above. We'll be enjoying a special presentation during lunch on AI by Dr. Croat. We have a raffle drawing again this year, and we'll be holding the drawing in the afternoon coffee break. Please see the conference desk, registration desk for any questions. The raffle is specifically is intended to encourage folks to interact with our vendor sponsors. I encourage all of you to go see and visit our vendors and enter the raffle drawing that way. This evening, there will be a reception at the conclusion of the meeting today after the day's lectures. Lastly, please don't forget to turn your cell phones on silent. Looking forward to the next 2 days. Please welcome Dr. Ben Ma, chairman of the Department of Orthopaedic Surgery, who will introduce our meeting this morning.
Good morning, and welcome back for all the alumni to the department. And I'm Ben Ma, the new chair of the Department of Orthopaedic Surgery. And looking forward to the two-day program. It's pretty exciting. We can see like the speakers. We have some exciting visiting professors with us, today and tomorrow. Obviously, we have Bonesboro tomorrow night. So make sure we interact with each other. The whole idea for the meeting is we're about bringing the alumni back to the department, so we can kind of get to know each other a little bit more and also support each other. So without further ado, I have the kick off the program. Chair to kind of lead us. I think the first would be the case conference, right? Dr. Craig Brown-Wilczak. Okay, thank you, Ed. So thank you. So looking forward to kind of interact with you more. Thanks. Yeah.
Amazing. Good morning, everyone. It's surreal to be up here. I've been coming to this conference since I was a med student, so happy to start it off today with the case presentation. First case is a 20-year-old woman, has left knee pain, swelling. First injury was 6 years ago when she was 14, playing basketball. She underwent an ACL reconstruction with an 8mm hamstring autograft. She returned to full activity at 9 months and plays collegiate volleyball. Currently, though, about 6 months ago, I started having pain, diagnosed as a hamstring strain, underwent some rehab for that, until she developed recurrent swelling while playing volleyball. She had a steroid injection with about a month of improvement and feels unstable, but she's able to keep playing. And then on exam, her range of motion, 0 to 140 bilaterally, it's a 2A Lockman, it's pivot glide, positive anterior drawer, catching with lateral McMurray's, but otherwise a stable collateral ligamentous exam. And then moving on to some imaging, see weight-bearing Rosenberg views here, show prior ACL reconstruction on the right side, left side, I'm sorry. Lateral, you can see there as well, the tunnels, and then a patellar view. Some numbers before we get into the discussion points. Her femoral tunnel was measured to be about 8.5 millimeters in diameter, tibial tunnel about 10.5 in diameter. Her posterior tibial slope was 9 degrees. Looking at the position of her tunnels, her tibial tunnel is about 43% anterior in the A to P position on the tibia. And then looking at the Bernard and Hurdle grid, the femoral tunnel is kind of a good position in that posterior proximal portion of the grid. And we also got standing alignment films, which show left degrees, 2 degrees of valgus, and then right about 1 degree of valgus. So let some of those numbers sink in. Looking at our current imaging here, see if we can pick things up, but I'll go back. The main things you see, the ACL graft, there actually are some intact fibers. It's kind of read by radiology as like maybe some partial tearing, but that fibers actually look, you can see them traverse. And then on the lateral side, she's got a defect of her femoral condyle, about 18 millimeters is what was read. 18 by 2. And this was her MRI before the ACL reconstruction. She didn't actually have that defect there, but she obviously had a clear tear of her ACL graft. Moving through. And we also got a CT for her, which doesn't show much new information, but you can kind of see the tunnels where they come out. That's in a pretty decent position. And so in terms of a discussion, I'd like to open it up to Dr. Wright, Dr. Louie. She's approaching her senior season, has been able to push through and play, but kind of how would you counsel her on letting her to continue to play? She does have collegiate volleyball aspirations, so that's something to take into account. And I think this was in like December-ish time, or probably before the season's here, so like September-ish time. So how would you kind of counsel her, Dr. Wright?
So what's her diagnosis?
It's a good question. So we kind of break it down into components. She has some amount of pain and swelling, but she also feels unstable. So I think there are kind of multiple problems to this issue. Even though their ACL graft is intact on MRI, she subjectively feels unstable and then objectively has some amount of instability with the pivot glide and anterior Lockman. So I think she has some amount of ACL instability, which could be related to the swelling, but also we see swelling in Carter's lesion. So, it's trying to decide which of the two are her biggest problems and kind of how you decide to treat them both or in isolation. I know kind of more about this, so I don't want to give it away, but.
So go all the way back to the beginning.
Yeah. So her.
No, slides.
Oh, sorry.
Please.
Let's see how I do this. Here we go. There we go.
So what do you think about 8 millimeter hamstring autograft?
Well, I mean, this is done she was seen in 2023, and so 6 years ago, it's like the mid 2010s ish, or 2000. If I could do math, 18-ish. But and so when I think about that now, I think that an 8 millimeter graft is kind of the smallest we'd want, and I know some good studies that show our stability trial that hamstring in that young female population in isolation of LAT has an increased risk for rupture. We didn't know that data back then, so there's something to be said there. But now I think there'd be some concerns about doing purely isolated hamstring graft in that age population, definitely.
What about full activity at 9 months?
So we don't have all the data on kind of what we used for return to sport criteria. This was done at UCSF, and presumably she went to UCSF physical therapy. And so I know they do a good combination of like single leg squat and like different dynamic testing to help return to sport, along with meeting with, the surgeon that did this to fully clear them. I think 9 months is maybe a little soon for the risk that she had for re-rupture.
Probably not terrible versus trying to rush them back at 6 months. Reasonable data out of Boston Children's that every month you wait after 6 months decreases the failure rate by 50%. I mean, we're talking a reduction of a small number to a smaller number to a smaller number, but getting them out to at least 9 months. A lot of people would try and push a 14-year-old out to 12. It's hard. It's hard. You get pressure from both the athlete and the parents at times. Did she have an event, do you think,
I think her initial one she did, this more kind of current course, I don't think there was a distinct event that caused it.
Yeah.
Here.
So when you're sitting with a patient in the exam room and they say their knee's unstable, what does that mean to you?
So give me a couple things. In the setting of a prior ACL reconstruction, obviously it could mean the graft is loose and or ruptured, particularly for for second time ACL tears or ACL tear which is previously fixed. Oftentimes or sometimes it's not like an acute traumatic injury as bad as it was the first time. It can be more this moment of instability that has some swelling and resolved with continued instability, so it can be much more of a subtle injury. From a injury perspective, there's some kinematic changes that happen kind of in I'd say a year after ACL, where the person is still gaining comfortability with their knee. So if they feel it's unstable and their quads are weak, there's some of that can be rehabbed through. So there's maybe intrinsic instability to the graft and maybe kind of extrinsic factors that can cause some instability.
Yeah, when a resident comes out and tells me that the patient says their knee's unstable, doesn't mean anything until you talk to the patient some more. And patients actually can do a pretty good job of distinguishing between quad buckling and ligamentous instability. And what I do is I just go, does your knee do this or does it do this? And they go, yeah, it does the first one. And so with her chondral damage and an effusion or whatever, she may be having kind of a pain-induced quad buckling that may not be instability. So you've seen any elite athletes performing at a high level with a pivot glide?
I can't name off the top of my head, but I'm sure there are many.
Yeah, there's a ton. Yeah.
Sure there are many.
If you're honest about your results, you got a ton of people running around with a pivot glide. I don't even know what Ben can tell me what a pivot glide is. I mean, it's like you either, I'm very binary. It's either shifts or it doesn't, okay? And that really helps you because I think that's what you got to decide here. Is this knee unstable due to ACL laxity, small graft that stretched out with time? Or is it problem with chondrosis? How big was the chondral lesion?
It was, I think, 18 by 22 millimeters.
Yeah, I couldn't tell. It didn't look that big on the MR. It was a
There's measurement over there, right, Alex? I think that
Yeah.
you can squint your eyes, get a little bit bigger. Is that right? Yeah.
I've seen it intraoperative, at least arthroscopy pictures. So I have some added. I'm cheating by knowing.
So if it was a 8, 9, 10 millimeter lesion, a lot of data out there that even if you see that at time of ACL reconstruction, you debride it, you can ignore it. Now at 18 to, so a 2 centimeter by 2 centimeter lesion, it's hard to feel great about saying, let's push through it and play a season with that kind of lesion, because if she truly wants to play, with that kind of lesion, I'm not sure that college volleyball is gonna make it anyway, but you're sure gonna beat that knee up with a senior season and club volleyball, and you probably have to have an honest discussion about, so it's 8 by 12?
8 by 12, sorry.
That's a little different. Yeah.
Smaller.
Well, I don't know.
Centimeter.
This is hard. Technically, it looks like everything was done well. Posterior slope, what do you think the posterior slope?
It was 9 degrees. I think I wouldn't consider any slope correcting osteotomies at that level.
Correct. Varus valgus?
I've tried to look up, it looks equal to the other side. I haven't found a firm number in my review.
Not enough to worry about, probably.
Yeah.
Because, we all know that the definition of insanity is doing the same thing over and over again and expecting a different outcome. So one of the things is that you have to walk in to talk to her, or at some point you have to say, if it failed, why did it fail? So that you don't have it happen a second time.
Right.
So alignment doesn't look like, dial test, posterior drawer, everything else is stable?
Yeah, everything else looks stable.
So you're not worried about subtle posterolateral corner,
no.
posteromedial corner?
But
Okay.
all good considerations too.
So if you're going to tell me that the ACL is unstable, why are you going to tell me? I'll give you three choices, okay? Traumatic, technical, biologic.
I say biologic would be my
Yeah, maybe.
answer.
Yep.
Given
Yep.
the graft choice.
Without an incident where she jumped, landed, twisted, and like you said, you've still got intact fibers on your MRI, so it may have just been a gradual stretching of a graft that's just not big enough to hold up to her demands.
Yeah. So. Okay. Well, we can continue to show what was done.
So what'd you talk about? How was the decision process go? And you can hand it off. You're having to answer a lot of questions. You can phone a friend.
I mean, I can answer questions. This is true. To save my residents some stress. I like sports. So in looking through the notes, I wasn't in her clinic visit, but the decision was made when she was seen to proceed with treatment. Treatment being diagnostic arthroscopy and looking at the ACL. The tunnels looked pretty well positioned and not dilated, so the plan, and we did think she was unstable.
Be your dilated number. What number would have pushed you to do something differently? Yeah.
13, greater than 13.
Ooh, you're pretty.
Maybe small, 15.
You're pretty conservative. Most people would say maybe 15.
Okay.
A lot of people let it get up to 15 before they graft it. So,
Yeah.
but yeah, 10 is fine.
10 is fine. So like a single stage ACL reconstruction was, we think would be like both technically feasible from a tunnel position and like dilation standpoint. And so the discussion was made to do an ACL reconstruction with a BTV autograft, with an LET, with the thought process that yes, like from a biological standpoint, the choice of an 8 millimeter hamstring graft in a 14-year-old female, a decent high risk of kind of re-rupture rate. And by using BTV graft and then adding an LET, provide more stability to what would be a high-level athlete. She's going to play in college. And then she had
Why
some...
are you going to mess with having to harvest another graft arm? Wouldn't it be easier to just do an allograft?
Yeah, it would, but she's still only in her 20s. And so, I mean, it's good data from the Moon trial that that's a high risk of re-rupture still by doing an allograft. So we elected to not do an allograft. And the autograft options...
Don't get me wrong, I wasn't advocating that. I'm just making you defend your choice.
And then between the other autograft options, between quad and BTV, I think we favored BTV, given her goals being high-level athletes. There's a secondary question of whether there's because you have volleyball, if you have kneeling knee pain with going down to hit a ball. I don't think that's actually been studied, but and it hasn't seemed to be a problem with her, but that was maybe somewhat in the consideration too, between those two graft choices. And then we did elect to actually treat the condyle lesion as well. Sorry, I misspoke. It was 8x12. And so your options between replacing with type 2 cartilage or type 1 being a more...
So what are your options?
So options broadly, as I said, type 1 cartilage options be chondroplasty or microfracture, which is fallen under favor, given violation of the subchondral plate and then not maintain MCID. Options for replacing type 2 would be OCA, like an allograft, autograft and oats, or you can do the cell-basic NACEs. And so among those options, the thought process here and what we chose, you elected to do an autograft for her. There's some good data out of Mayo that shows it's a quicker return to sport and higher percentage return to sport. And so that's what we chose to do. With that size, with 8x12, you won't end up taking too many plugs, so it's feasible. If it was larger, then you're kind of limited on your autograft options. But that was our thought process from reading her notes.
Okay. You want to show me what you did?
Yeah, wish I could say I did it, but it was done by a person in this department. So this is the wall of the femur. You can see that she does have ACL fibers, but kind of empty back wall. And so that MRI will show fibers going somewhere, but really where we expect them to be, there are no fibers remaining on the femur.
Did she shift when she was asleep?
I didn't see her in the operative note. I believe she did shift when she was asleep, but I didn't. There we go. She did shift when she was asleep.
You would expect that now, seeing that graft.
Yes. And so we did an ACL reconstruction, the BTB. This is our pin in the femur, still the femoral tunnel. These sutures are in the bone plug of the BTB to help us pass the graft, which is then fixed with an interference screw. And then on the tibial side, also tunnel. You can see up the tunnel, nice bone, pretty much circumferentially, maybe some soft tissue here, but still good bone throughout the majority of the tunnel.
So did you use the exact same tunnels?
I don't believe they use the exact same tunnels. There probably is some ton overlap, or did we? We did use the exact same tunnels.
The femoral tunnel was like 8, 9 millimeter, but was able to just expand around that. And then the tibial tunnel was well positioned and just used the same.
What is well positioned on the tibia? Not to pimp you, but
Yeah, so looking at the radiograph, it was I think 42, 43%, which is in line with what we would expect. The MRI and CT also looked well positioned. I think the central point, just in line with that posterior horn of the posterior border of the anterior horn of the lateral meniscus, and then just between her tibial spines centrally. So everything about it looked well positioned to me, and wouldn't see a need to change position.
yeah, I would agree, but you'll see it 11:30 or whenever. That one of the predictors for a worse outcome is when you and I think it's an ideal tibial tunnel. And so that's why I ask you, because what I think you used to think is an ideal tunnel, I may not know. And so we're probably going to need to take a look at why these tunnels that you and I and everyone in Mars thinks are ideal are not ending up, as they're end up as an independent predictor of worse outcome. But yeah, I think that looks like a great spot to be in with the tunnel again. So, all right, what else did you do?
So this is a lateral cartilage condyle injury. And we did, as I said, an OATS, so autograft. This is the recipient site, the screw. This is our first plug. We did a snowman. So you can kind of see the edge here is that edge there. So this is our second recipient site. And then these are the donor sites in the lateral trochlea, which we backfilled with allograft. And this is the final osteochondral allograft with 2 8mm plugs, and then our revision ACL.
Yeah, that looks good. You did LET also?
Yes. we
Yeah,
also did
so
LET.
the one thing on the full extension lateral is it looked like she might hyperextend a little bit. What we've shown, Dan Cooper actually looked at our data and found that if you extend more than hyperextend more than 5 degrees past neutral, you double the failure rate after revision. So I think definitely this kind of athlete, and if they hyperextend at all, it probably behooves you to do an LET. But this is how much the field has changed. 1,200 revisions in Mars and just a handful of LETs done by John Albright, Ben, at Iowa. The only person in the entire, out of 83 surgeons, the only one that did any type of extra-articular lateral side. And now, if we redid Mars now, probably half would get it, maybe more. So,
All right.
no quads in the study either. So it's how much a field can change in 5 or 6 years.
But that's a good comment over there, Rick, because I think when we asked the audience over here probably 5 years ago, none of us would do a LAT on the revision. And now I would say probably maybe I don't know, anybody would do a LAT when they do revision ACL in this patient?
What's an LET?
Lateral. So LAT, lateral tenodesis, lateral extraarticular tenodesis. Alex, you want to share with the group what LET, does over there, especially for our trauma colleagues, which kind of love soft tissue,
Yeah.
right? So let's share with them. Share with them what we do. Yeah.
Yeah, and
They'll start doing it on tibial plateau fractures or something.
Yeah.
Don't you start.
we have no pictures of it, but in our practice, it is using part of the IT band to recreate the anterior. There is a true anterolateral ligament reconstruction, but it's to recreate that moment of rotational stability that's lost after you tear your ACL. And so what we do is we take a strip of the IT band, and then we leave it attached on the tibial side, and then you tunnel it under your ACL, and then you dock it in your
LCL.
I'm sorry.
Yeah, hard
I
to
said
do
ACL.
ACL with
LCL, lateral. And then you dock it in your femur through different mechanisms. For this one, we did like a suture anchor kind of locking on one strand, slide and pull, and then pulls the anchor, the graft down to the anchor. You tie it all together.
Yeah, so idea is extra-articular, so have more rotational control. But any downside for LET? Like, we talk about how great LETs are over there. For this patient, any downside, Drew, that we think about?
Yeah, so one of the concerns is, are you over-constraining the lateral compartment? And I think for her, that's especially of concern with her lateral femoral condyle cartilage injury. But a lot of studies have suggested it. There are like fluoroscopic studies from Pitt, where Alex will be a fellow in 2 years, that kind of show that may not be as much of a concern. I think it's balancing that risk of re-tear and graft failure versus this more theoretical concern. And I think with the osteochondral autograft, her cartilage should be in good shape. And my favor was protecting the graft over that theoretical concern. But I think that's something to think about and something I think we don't totally know.
Yeah, Ben, anything that's widely adopted with minimal follow-up, just stay tuned. We'll figure out some things that we don't know today. But it seems like in this kind of setting, it probably makes sense.
I think for the audience, LET is actually not a new concept. It's been around for about almost like 30, 40 years, depends on how far you look back in terms of people doing extra-articular tenodesis type work. But obviously, there's a lot of interest in it right now. But I think longer-term follow-up would be helpful. Yeah.
Yeah. We'll see. I think that's a rehab course for the cartilage.
I've got a question for Dr. Wright.
What?
So, for example, if this patient did not want her patella tendon harvested for the revision, what options, or Dr. Wright, what do you prefer to use for your revision ACL if a patient does not want their own tissue?
Well, we would have a long talk about why they don't want their own tissue and want to go back to that kind of level, because it's at least 3 to 4 times higher failure rate. The longer, I'll show the data later, but 2.78 times risk at 2 years allograft over autograft. So I've not had anyone after I talked to them and explained to them. And we don't know that age. We think, obviously activity probably helps protect you. We don't know that age is not shown in allografts to be protective for revisions like it has in primaries. So the allograft risk may continue to be pretty high even as you get older. So I would say, I think that if you have any thoughts about remaining active and any thought about trying to get back to volleyball, we need to do an autograft in someone that's, 20 now? 20, 21?
Yeah.
Yeah. But, yeah, so we would have a thoughtful discussion, and I think most people would hear that and say, now, before we did the Mars, I would, if they'd had a previous BTB, I would go to the opposite knee. But then the Mars data showed that the hamstring results, the soft tissue results, were as good as the BTB. We could not show a difference. So I stopped going to the opposite knee and now use hamstrings, and knock on wood, don't know that one of my hamstring revisions have failed. Haven't done that in a truly elite athlete. But so now I don't go to the opposite knee as often. But I did that about 100 times. The opposite knee, actually it's a great operation. You realize that harvesting, I mean, they get better really quickly because you kind of do a little bit to both knees. So I was very pleased with those results. But you always, if you don't have to operate on the opposite knee, it's better to avoid that.
Yeah. All right. Well, in the interest of time, we will move on to our next case.
Yeah, of course. Hey, I am Alejandro Casalino, but I go by Kaz. I'm one of the fourth-year residents as well. And we're going to be going down a little bit of a different pathway. Right now, we're going to be talking about some deformity correction. And this was a case that was done by Dr. Candemire. And I have nothing to disclose. So this is patient CG. She's a 31-year-old female, otherwise healthy, who had a wave runner accident at the age of 11. She presented with a left open tib fib fracture as well as a mid-shaft femur fracture that was treated with multiple surgeries back when she was 11 years old. She presented recently, when she was 31, to sports clinic actually with left knee pain and a left lower extremity deformity. Of note, she's taking occasional Norco. She's otherwise very healthy 31-year-old. No other medications aside from the Norco. She is a banker, denies any tobacco or any other drug use. On her physical exam, she does have a leg length discrepancy of a left shorter than right by 2 centimeters, as well as a valgus and hyperextension of the left lower extremity. Her knee range of motion was documented at left -30 to 130 and on the right -10 to 150. So as you can note, bilaterally has hyperextension, but then again on the left has quite a significant amount of hyperextension. And she is distally neurovascularly intact. So we'll get right into her imaging here. So as you can imagine, when this patient presented to sports clinic, we decided it probably wasn't the meniscus injury. So she has a significant osteopenia here of her left knee. You can note the procurvatum of the distal femur as well as the recurvatum of the proximal tibia. She has some hyperextension of the knee, loss of her normal tibial slope. And then you can also see here on the attempted AP of the knee that this is not a true AP given the fact that she has this deformity. So here's the AP and lateral of her tibia, which gives you a better sense of where the primary source of her deformity is. And then also took a few measurements here. So it took the angle of the measurement of the deformity in both the sagittal and coronal planes. You can see that the primary deformity here is in the sagittal plane, which is a little bit different from our normal deformity cases or our more typical deformity cases. The angle I measured here was her chora at about 24 degrees. From a line perpendicular to the tibial plateau and a line perpendicular to the distal tibia. And then you can also see that the core is about 7 to 8 centimeters distal to her tibial plateau. Additionally, sort of one other thing to think about here is that given the native tibial plateau anatomy has a posterior slope of, around an average of about 7 degrees, does this chora take that into account? Not necessarily. So if you are trying to restore her back to her native anatomy, and again, we'll look at her contralateral side, you might be aiming for something closer to around 30 degrees or so. The apex, you can also see here in the coronal plane, she has a small valgus deformity that I measured at about 3 degrees. But again, mostly in the sagittal plane. Here are her full-length standing films. Overall, we can see that she has that 2 centimeter leg length discrepancy that was measured clinically as well, left shorter than right. We can also see she has the slight valgus of the left lower extremity as demonstrated by the MAD compared to the contralateral. And then also took some measurements here of her coronal plane deformity. Again, not as relevant in this case, and again, slightly thrown off by the fact that we don't have a true AP of her knee, so it makes it difficult to get reliable measurements. And then here's sort of where the money is. Here's her lateral full-length standing films. And we can see here that on the right side, her posterior slope is about 5 degrees. On the left, it's about 16 degrees anterior. So the difference, again, between her injured and uninjured side is about 31 degrees. Again, these are not perfect laterals, not the ideal x-rays. You can see the rotation based off of her femoral condyles. And then the other thing to note here and to think about is the compensation that she's having given her deformity. Typically when patients have this recurvatum of the tibia, they have a stretch of the posterior capsule, which leads to hyperextension of the knee. So just one other sort of thing that we were thinking about as we're going through this case. So that was a lot of talking from me. Just curious if you would get any additional imaging when you see this patient. Is there anything else that you'd be thinking about in terms of your workup for her?
Well, Ben wanted me to make this an interactive experience. So if you're a second-year resident, can you raise your hand, please?
Second year. Raise your hands, guys. Come on, don't be shy. Half the hands up over there.
I guess the second years have alligators. What's going on? Raise them high. Yes, on the far left. So, do you think you have enough information?
I think that potentially you could think about a CT scan, but other than that, I do think that the scanograms are a good amount of information.
Okay. Would anybody get MR imaging to assess the ligaments? In fact, did you do that or not?
We did not.
And how important is that in your decision if you're going to tackle this? Some significance, little significance? I'm going to try to get Dr. Wright involved in this case as well.
Surprise, it's an ACL case. No, I'm just kidding.
Exactly. Okay, so let's go back to the x-rays, please.
For sure. Any particular ones you'd like to go to?
That's great.
There we go.
Actually, go to the AP alignment films first.
For sure.
So you correctly identified that this deformity is pretty much in the sagittal plane, correct? And I'm not too impressed by the valgus, although it can be corrected. So we have, if you were to list the problems, what is your list? Because it's important before you tackle something like this to list all the problems that you think need to be addressed.
Yeah, for sure. So I think the main problem, as I've mentioned here, is the sagittal plane deformity. So she has that recurvatum of the tibia that's due to the non-union of her previous tibial shaft fracture. She has the slight valgus, again, very mild valgus deformity based primarily off of the tibia. I think there's some subtlety also to the anatomy of her femur. I didn't focus on that as much here, given I think the majority of the deformity is originating from her tibia, but I think there are certain things on the lateral of the femur. You can see that she has a slight S-shaped deformity of the femur as well, but I think I focus primarily on the tibia here since that's sort of where the money is.
I think you did a very good analysis, and I think Dror Paley and his colleagues have really opened our eyes to where the deformity is, and you identified that it's just not in the tibia, but it's also in the femur. But the question is, practically, where do you want to attack it? So how much of a leg length discrepancy is real if you basically extend the leg so it's straight, or how much do you think is real shortening?
I think it's not really real. I don't think it's necessarily from a bony deformity. I think if you were to straighten out the leg and to have both legs straight, she probably would have similar length legs.
So let's go to the fourth year of residence. Yes, thanks for raising your hand. A microphone's coming to you. So what treatment options do you think you have?
Well, we identify that most of the deformity is coming from the tibia, so you can acutely correct it or gradually correct it. Osteotomies.
So osteotomy is going to be in play for sure. Opening wedge, closing wedge, distraction osteogenesis, fixation, internal, external. What do you think?
I think you could do all of them. I think if you're just correcting one plane, then it's a simple procedure to do just acute correction. If you're correcting in multiple planes, then the thought is that you can better correct in all of those planes, especially if it's in like 3 planes or a biplanar deformity.
So in terms of osteotomies, opening wedge, closing wedge.
Sorry. Oh, yeah, sorry.
Yeah, but they were saying the leg length discrepancy is not real, right? I mean, if you were worried that you needed to gain length, then you would want to open, not close. But I don't know if I know which one's best for this.
Okay, that's fair enough question. Any other weigh in? Raise your hand, please.
So,
I think that for this, it's hard to know what the exact true length of the tibia is, and then we don't really truly know whether or not there's a rotational deformity component to this as well. I would get a CT scan to further evaluate the profile of the tibia. I think that a maneuver like an osteotomy with subsequent distraction osteogenesis is a more precise type of deformity correction than if you were to do an osteotomy. Oftentimes I feel that when you're doing an acute correction, it is a lot of guesswork. Guesswork.
Guesswork, yes. Okay. And we have a very surgeon in the audience, Sanjeev. Sanjeev, I think we probably think alike on this particular case. And unfortunately, those of us who do distraction osteogenesis were accused of having a hammer and everything looks like a nail. So with that being said, what do you think, Chief?
Well, Kevin, first I want to acknowledge Dr. Morshed. There's lots of deformity surgeons here, but I'll chime in. Well, the other thing that wasn't brought up is I think there's patella baja on that side compared to the other, and that probably plays into the decision making too, in terms of are you going to go above the tubercle or below? So that's sort of another, PG5 level question. But no, I mean, I agree with everything. I think it's nice to quantify back to sort of the Baltimore numbers, how much of the procurvatum is coming from the femur. So you sort of dial it in when you do the correction. And so, yeah, I think finally I agree with sort of, and of course I'm biased, but I think a gradual correction perhaps is more accurate and safer. Because if you do let's say an opening wedge, there's of course union issues and et cetera, et cetera. You do you could sort of, well, you won't really stretch the bundle that much, but there's always those issues, fasciotomy prophylactically for possible compartment syndrome. So, and I think there's a couple of papers out there comparing head-to-head acute versus gradual for tibias, saying gradual is more accurate, which makes sense. So I would err towards gradual, and then the debate is above or below the tubercle.
What Sanjeev point from the standpoint below or above the tubercle, I think I would do my osteotomy below the tubercle personally, so we don't disturb the patella biomechanics. I would be in favor also of distraction osteogenesis.
excellent.
I passed.
Hey, Kevin, I'm speaking from a sports person over here. So the traditional measurement of alignment, it doesn't really work over here, right? Because the patient's not even standing up straight. And should we focus on individual, measuring the femur itself, the distal femoral angle, the tibia in terms of the length of the tibia? I mean, we talk about we don't know the length of the tibia. You can measure on the lateral, right? What the length of the tibia instead of just, the overall length, LLD is probably not so helpful because it depends on how much hyperextension, right? How do you strategize this in terms of looking at real limb differences? Do you just measure the actual bone itself instead of overall?
That's the most accurate way.
That's probably
Sanjeev, you too? Measure the bones and not just take
exactly. Femoral, both the femur and the tibia, because she had a childhood injury too. Yeah, I agree.
And from a practical standpoint, I think not touching the femur makes sense. I think we can get good enough correction for all the work to be done just in the tibia.
Awesome. I had sort of one other discussion point before we move on to what we did. So, I think oftentimes, at least in my experience, when we've talked about coronal deformity, there's a very rigid framework for how we're thinking about this. In sagittal deformity, I find, or at least I've read, that it seems like we accept more deformity in the sagittal plane than we do in the coronal plane. Do you have, a cutoff? Obviously, this is a pretty extreme case where we need to do something to help her sagittal plane alignment. Do you have a framework for how you think about sagittal versus coronal plane deformities and, why we accept more of the sagittal plane? Obviously, there's compensation through more of the joints, but your thoughts on that?
I think the posterior slope is such an important aspect of the proximal tibia, so that kind of guides me as to how important I think the sagittal deformity is.
Okay, great. All right, well, I'm glad we did do the gradual correction. So these are her immediate postoperative x-rays. Again, we did a 2-ring construct, both proximally and distally, and we made those rings parallel to the joint line. And the way that Dr. Candemir does his osteotomies is he uses a drill and then completes with an osteotome. And then I have a couple of clinical pictures here as well. So again, this is just what the construct looked like after they had completed the operation, and this was a preoperative image as well of her legs. And so, I think there's some discussion about how people actually perform osteotomies. You could use a reciprocating saw or a saw of some sort. The idea of using a drill and then completing with an osteotome to cause less heat, thermal necrosis of the tissues to help with your healing of your osteotomy. What do you do in your practice when you're doing these types?
So the original Ilizarov technique is to corectomy. And what you do in that situation, you try to preserve the intraosseous blood supply and the periosteal blood supply. And that's the reason why we pretty much, and I'll talk about this a little bit tomorrow, we never use a saw because the heat generated by the saw will kill that periosteum and endosteum, and you'll have a difficult way of achieving bone regenerate. Some people use a jigsaw. I find that particularly scary when you're so I do what you did. It's called a Debastiani technique, multiple drill holes, complete with the osteotomy. I think it's the safest.
Perfect. Another question I had is, in the era of regional blocks, it seems that all of our patients are getting blocks. Would you allow a patient like this, or would you talk to your anesthesia colleagues about not doing a block for a patient like this when you're performing a tibial osteotomy?
Yeah, I'm old school from that regard, so I don't have any regional anesthesia. I want to see if a muscle's twitching, then I'll know right off the bat.
Great. And then do you do similar sort of ring constructs as well, sort of 2 proximal, 2 distal, or do you use wires and half pins, or we're getting into the nitty gritty, we can move on also because this might be trauma specific.
Go back to your clinical pictures of the frame in place. So this is kind of the classic, and the biomechanics of external fixation are still the biomechanics of good fracture fixation as well. So I think this is a well done frame. For those of you not using it, those are for frames, and particularly x-rays, you're mesmerized by how much metal there is in the picture. Once you are familiar with the device itself, see, is this a stable construct or an unstable? Look particularly at the x-rays, it was very stable. Combination of half pins. The Ilizarov that only used transosseous wires. So your knowledge of cross-sectional anatomy has to be very, very keen. But I personally used half pins in these kinds of constructs and had.
Excellent. I'm just going to move on since I've gone for a long time here already. So this was her first x-rays after starting strut adjustments. So part of this is that you can gradually adjust the struts. So this was her 5-week post-op, and that this was after her first adjustment. And you can already see here that her alignment has already improved quite considerably. And then this was her 9-week post-op. She had just completed her final adjustment. And then you can see here the overall correction of the tibial slope, which is back to maybe a couple of degrees of posterior slope, which was our goal here. And then I think some questions, how you perform your dynamization, just a little bit of background. So dynamization is basically once you have put the struts into their final positions, you loosen the struts. There's various different protocols for doing that in order to allow, basically from what I understand, it's almost like a stress test of your osteotomy to see after it's healed, whether it's going to fail or not. And so do you have a protocol for your dynamization? Does each patient vary, or how do you think about the dynamization process?
Yeah, so when we're using the hexapod frame, just removing one strut, we destabilize that construct. And unfortunately, it just doesn't collapse axially. It actually rotate. So you're introducing a little bit of shear force. So clinically, I want to make sure that patients have pain, they're fully weight bearing, and I will take the struts off, leave the rings in place. If they're complaining of the osteotomy, then I know it's premature to remove the frame. So that's my role, my idea of dynamization. Unfortunately, in that frame, the rings were not necessarily parallel. So if they are parallel, then I'll put threaded rods so you can actually improve the axial microcompression and not destabilize it?
Yeah, so we sequentially released the struts to sort of over time make sure that she was staying stable and was not having any pain. Unfortunately, she did not have any pain. And I'll just sort of do one last question. You know, part of the issues with these ring fixators is the tolerance of the patients. Do you ever think about, you know, decreasing your time for consolidation, putting rigid fixation, whether that's a nail or plate and screws, and taking the ring off earlier? Or do you like to keep the ring on as long as you possibly can?
Ideally, I like to keep the rings on as long as possible because I think the biologic footprint of just an external fixator isn't as great as a plate or intramedullary nail. But I wouldn't hesitate. If patients are just not tolerating it, then we would probably move to some form of fixation or casting.
Great. All right, I've gone for too long now, but here are some of, this is immediate removal, and then this was her 6 months post-operatively, so we can see that we've overall improved her alignment going from the red box to the green box, so corrected some of the valgus deformity as well.
So the 2 centimeter leg length discrepancy, that was basically based on an AP view and not really the bone length, correct?
Exactly. Yeah, so she's very happy, doing great.
Nice case.
Thank you.
All right, good morning, everyone. I'm Fabian Su. I'm a PGY4 going to shoulder elbow. So this will be a case on shoulder instability. So this is a 25-year-old right-hand dominant individual who presented with a right anterior shoulder dislocation after a ground level fall 8 months ago. Since then, the patient has had 6+ dislocations and continues to complain of shoulder instability. This patient is like any other San Francisco techie, doesn't play any sports, is a software engineer. Doesn't smoke and smokes marijuana heavily. So on exam, the patient has full range of motion and strength, positive apprehension and relocation, a 2+ anterior load and shift, and no signs of hyperlaxity. We can see here on the radiographs that on the AP, it's uncertain whether or not there's a loss of the anterior sclerotic line, but we do see a central head humeral head deformity, as well as a Hill-Sachs lesion. I'd like to ask our invited speakers whether or not you would get any additional imaging, and if so, what kind?
So, if you're PGY4 or 5, one of the Chiefs, Ben.
Dr. Mao, thank you for this opportunity. Yes.
Well, welcome to the morning. So do you need more imaging, and what's your thought process, and what imaging do you want, or do you know what you need to do? Recurrent dislocator, go to the OR. It's going to be in front of you. Take care, tell the patient ahead of time what you may need to do.
No, I mean, I think while it doesn't look like there's much bone, basically what I'm worried about in a recurrent dislocator is bony loss, and particularly of the glenoid. You know, on the x-ray, it doesn't look terrible. However, I just think it's important to, you know, assess that. So I would get a CT to further assess the glenoid for cross-sectional imaging in particular.
So just a CT?
That's what I'm thinking. It seems like you would like me to get more. We could always get an MRI.
No, looking at this, I'm really old school and cheap. I might go to the OR. It's going to be there, and I'm going to deal with it. You know, you just.
Yeah, I can immediately think of reasons how a CT can help me. I'm not sure in terms of MRI. He's a recurrent dislocator. I know I'm going to do. You know, I need to know whether or not I need to do bony work. I know I'm already going to do soft tissue work. So that's why I'm not sure if the MRI is helpful.
Yeah, so realistically nowadays, most people would probably get an MRI. If there's any question on MRI of bone loss, I want to quantify it best. I think you're right. I still think the CT scan's the best. But the only thing I would worry about with this case that I needed imaging would be if I thought there was some way that it was avulsed off the humerus and not off the, if it's not a classic Bankart, because that would dramatically kind of change what you do, and you need to be able to see that and identify that intra-op. But if you go in and it's a standard Bankart, you'd have to decide at the time what you're going to do with the humeral head. There's a Hill-Sachs, but maybe there's not that much bone loss here. But every one of you, 2 years from now, when you're or 3 years from now, when you're in sports and doing your boards, you're going to have MRI and a CT scan. And my partners will look at me crazy when I say, well, it's a ACL tear. I'm not sure I need an MRI sometimes, but it's just pretty uncommon now to not get this type of imaging. So.
Yeah, and to reiterate Aviana's point, there's definitely a concern for bone loss with a multiple dislocator. In Canada and other places where there's universal healthcare, it's a lot harder to get an MRI, and some people will just elect for a CT scan alone.
If I had just a little bit better axillary, I'd feel just a little bit better. It's just enough of an overlap that you really can't see that anterior glenoid quite like you'd like. But so what'd you find?
So on the MRI, you can see that the patient has a moderate Hill-Sachs deformity. They do have this weird depression of the humeral head. And then on the MRI, you can also see that the glenoid anterior inferiorly, there's a tear of the labrum, and that there's a little defect of the anterior inferior glenoid bone. So we also obtained a CT scan, and I've shown some measurements here. They have 8.6% glenoid bone loss. The Hill-Sachs is on track with a distance to dislocation of 3.6 millimeters. Like to ask the visiting professors, is there any other preoperative measurements that you would do to try to gauge what you would do surgically?
Probably don't need much more to plan what I think I would do.
All right,
maybe
so
I'll ask the question to Hunter over here. Like, what do you think about that anterior kind of humeral defect? Is there anything that worries you about that? And maybe like why is it there? What do you think?
Yeah, I mean, it raises concern for potential, posterior instability. Maybe there was, some damage to the anterior humeral head during that. So, potentially thinking of a more globally unstable shoulder at this point.
I think that's important, thing to pick up over there. Obviously, we didn't see that well in the plain X-ray, but for someone that unstable, this may be like, kind of anterior posterior labral tear. This is an anterior and posterior instability, and just kind of, have to be more cautious about what you want to do intraoperatively, right? So, yeah.
Would you do anything with that, Ben? Look at it at the time and make a decision intraop?
Correct. Yeah, they are. Most of the time, they are smaller than you think it is, because they kind of almost like a reverse Hill-Sachs. But something to be aware that you may not be just an anterior labral repair. You may have to do something in the back on these patients over there. Yeah.
What do you think about the anterior bone loss? What number would have made you a little nervous and you might do something, and what number would tip you into doing something for bone loss?
Yeah, I think the literature has gone a little bit aggressive on what the critical bone loss is. I think critical bone loss is probably 20%. Subcritical glenoid bone loss is about 13%, 13.5%. I like to use the Peter McDonald study from JSCS in 2021. He uses 15%. So that would be my cutoff.
With the way it's headed, I think before I retire, we'll be down to 10%. But
so, Rick, I would say that I'm not a nervous person over there, but I will ask Drew over there, Drew Lansam, when do you get nervous about it?
I don't get nervous. I think it's a combination of what the humeral side looks like, because I think the Hill-Sachs definitely influences also. But past the 13-15%, and then it's also patient activity, their goals. It's I think a complex problem, but 15-20% for sure.
I know the number's dropping, right, Brian? I think at conference we see them down to like 13% over there. So yeah, it's great. Yeah.
All right, so this is a patient with less than 10% glenoid bone loss, an on-track Hill-Sachs lesion. What what would you decide on for this patient surgically?
So I probably would not think that you need a Lectureship or bone procedure at this point, although you can do that as your primary procedure. And in Europe, if you're in France, that very likely might be what you get. And, you know, Gilles Walsh, what's he done, Ben? 1,500, never had a complication that he
Correct.
presented at AOSSM about three years ago on specialty day. It was like mind-boggling numbers.
No
that
failures, no hardware problems. over
never
there.
had a stitch abscess, never had a single thing. Yeah.
But he has
Wow.
no follow-up too, maybe that's why.
Another chief resident. We going to be able to handle this with arthroscopic bank art? Or are we going to need to do something more?
I can't quote you primary data, but I would say that the size of the hill sacks and the number of dislocations makes me want to consider option B.
Yep. I think that Ben and I have been doing this long enough that first 20 years of my career, remplissage bad. Verboten, stiffness, pain, misery, suffering. Now remplissage good. Same operation, I think, except we, doing a little more arthroscopic. I think 10 years ago, this gets an arthroscopic bank art and a fingers crossed, and we move on. Now I think it would probably get a remplissage. We'll find out in 10 years if remplissage is bad a second time around, but like the pendulum always does, no matter what the question is, it swings. But I think a lot of people would still do this with arthroscopic bank art, try and get that reconstructed tight and then hope it doesn't come out again in a person that is not playing football or hockey, that's just smoking dope,
Yeah.
This same person lives in Tennessee, they just have a BMI of 45.
All right. So the attending decided to do a Lectureship procedure. I was wondering if anyone could comment on whether or not this procedure is performed technically well.
And we'll let Brian comment on the technical aspect of it.
Yeah, so I let Fabian Sue put those screws in, and Fabian said we were a little bit too far on the glenoid face. So
No, I think it's done technically well. The coracoid grafts below the
So
equator.
I would like to point out that when Fabian showed me these images, he pointed out that we were a little bit up on the glenoid face, and he asked if he should point this out in conference, so I'm not going to let you slide on this. But since we were looking right down the face, I think it actually looks okay, and the x-rays looked okay. So I do think it brings up a good question when to lean towards soft tissue versus bony, and the decision-making process on this is the guy, even though he does smoke a fair amount of dope, he does think that he was a little bit more higher demand. He does do what he thinks are high-risk activities, and when we measured him in conference, we felt that he was more in the 12 to 15% bone loss anteriorly. That plus the decent-sized Hill-Sachs defect, I thought was a little bit much to manage with an all-soft tissue procedure. Now, in hindsight, maybe it was better to do with a all soft tissue procedure, but I'll let Fabian keep talking.
Yeah, and I just want to point out that it may look like it's overhanging, but again, there's an articular surface so that the bone is flush with the articular surface. So the patient was in a sling for 6 weeks. 2 weeks later, the patient redislocated while violently vomiting. The partner says that the patient appeared to have a seizure, and they were seen in our local ED with an recurrent anterior shoulder dislocation. As shown here, you can also see that the Lectureship screws are broken, and patient was closed reduced and discharged on Keppra. So the patient ended up following with the neurologist, and it was determined that they may have had a generalized tonic-clonic seizure back in 2022, resulting in their fall and initial shoulder dislocation. A workup for their seizures was done, and EEG and MRI were normal. The patient opted to forego anti-epileptic drugs and manage the seizure triggers, so they stopped smoking heavy dope, and then did some stress management. So they are given a suspected diagnosis of focal epilepsy, and the patient is now 3 to 4 months, quote unquote, seizure free. We did obtain repeat imaging. I think that the bone loss is still about 8.6%. The Hill sacks did increase in size with their most recent dislocation, and it's still on track, but barely hanging on with a distance to dislocation about 0.2 millimeters. So with this information now, the patient has a failed ladder J and recurrent instability. What are your next steps? How do you determine the timing on revision for these patients with epilepsy?
Boy, it's I think really challenging when it's kind of a history, but you try and get quite a ways down the road. The longer you can wait to make sure that they truly are controlled, it'd be nice to be at least 6 months to or so. Year would be even better. You're probably not going to get a year out if they're having instability. It's a real shame because I think it appeared to be a well done ladder J. It should have, This, how did you handle the labrum at the time of the ladder J? Yeah. All right, another chief resident.
I'm actually asked Dr. Ruck over here,
Okay.
one of our alumni. Caitlin, what would you do? Like when you have a failed ladder J, what's how your thinking process right now? Usually I refer them to Brian. That's what I do. So,
yeah, refer them up to UCSF. It's interesting. He didn't have a lot of bone loss to begin with, and his coracoid process bone on the CT scan, there actually is still some bone there, which is surprising. I think because it's so early, the bone quality, it's still there. So, there's definitely some different considerations. One of the considerations now is, do we need to address the Hill sacks lesion? It's gotten bigger. I think it's contributing to the recurrent instability in this case. So that's definitely something I would strongly consider, whether to do a remplissage at the time of a revision bony procedure or considering an allograft. However, I think at this size, I would probably go with a soft tissue-based a remplissage. And then for the anterior glenoid, you basically have two options. You can try to revise your coracoid fixation, or you can go with a distal tibial allograft. And I think in this case, I would lean towards the DTA because I'm worried about the bone quality of the coracoid process. And I'm also, just as a side note, the posterior instability now seems like a lot more of a possibility with his seizure history now. We saw that big defect in the humeral head. And so I think probably he did have a posterior instability event and possibly related to his seizures.
Yeah, you may want to look at the posterior labrum. And this is one of those about halfway into the case when you're trying to get that coracoid off the glenoid to then put down a allograft, you go, man, maybe I should just lived with the coracoid. But that's a decision. The problem is with the allograft is that you have to commit to a 10 or I don't know what a distal tibial allograft. I don't know what that costs, but everything that you do that's osteochondral or graft of that type is going to be 10 or 20,000. So you got to buy it ahead of time. So now you're committed. Then you get in there and you're struggling to get what you thought was going to be a coracoid you could just knock off. Now it's healed, and yeah. Ben, don't schedule this one for an hour, okay?
So Fabian, my question is on that CT scan, did that ladder J piece actually still heal even with the broken screws? Because it's on there. And let's say you guys are a little bit too on the face. Now it's actually recessed back more to where we like it, if it healed there a little bit.
Yeah, I was looking through. There was no, I think it was a little too early for true integration. The graft was still there. There was no resorption. It was a little bit medialized. So you do think that it no longer serves like a very good articular surface for the humeral head to like roll against. So I think that it doesn't really serve the purpose of giving a glenoid track anymore. So I would revise it.
Well, I mean, you don't need it to be on the surface for a good ladder J. You still have the sling effect, and you still have that bony block, even if it's not articulating, right? So you could think about having that, let that heal, and then just do a capsular plication on top of that with the remplissage and not messing with the bony part, actually.
That actually might be what I'd do. Look at the CT scan pretty closely. If it looks like it's healing, or go in and revise the Latarjet hardware and soft tissue and a remplissage. But a lot of different ways you could handle this. What'd you end up doing?
They ended up doing a distal tibial allograft reconstruction. Nothing was done for the humeral head. And patient was seen 2 weeks. Feels great. We'll see how they do.
Yeah. Good. Looks good.
Yeah, I think that we kind of forget about open capsulorrhaphy, right? I think the field really changed from open surgery to arthroscopic surgery, and now we do these bony surgeries. But I think that capsulorrhaphy worked pretty well also, especially I think in this case, I'll probably do like a big T capsulorrhaphy, do a big near, kind of a stabilization, especially for someone that posterior instability works pretty well also, yeah.
How many of the chiefs, raise your hand if you've seen an open Bankart reconstruction? One?
Thanks, Hunter.
How many of the chiefs have seen, scrubbed on, an open Bankart reconstruction versus arthroscopic Bankart? Yeah. It's a great operation, and it really works well. And if you are taking care of a football team, it's a great operation for linebackers and people that, don't care. You don't care if you lose 10 degrees of external rotation. But, yeah. And no one knows how to do it. I would get the same response in Nashville. So it's just, we don't do them anymore.
Great. Okay, we're going to swing back towards the deformity side. My name is Stephen Garcia. I'm one of the fourth year residents. I'm going into PEDS in 2 years. So we're going to talk about BB, and this is a case of bilateral genu-varum. So on presentation, he was a 16-year-old who presented with chief concern of bowed legs for the past 6 years. He doesn't have any pain or discomfort, and he plays competitive soccer and basketball. And he says he plays those fine without any issues, just bothered by the appearance of his legs. Otherwise, he was healthy, he met all his milestones. He was born a month early for the parents, but otherwise hasn't had any surgeries. On his exam, just to kind of smooth ahead here, you can see his clinical pictures, and he has clinically on the right side 7 degrees of varus, and on the left 10 degrees, and his rotational profile is pretty normal and equal on both sides. And then here we can see his standing coronal and sagittal alignment films from his scanogram, where his medial axis deviation is about 2.5 centimeters bilaterally medial, and looks like most of the deformity is coming from the tibia, with his proximal tibial angles of 72 degrees kind of bilaterally. So kind of the first question we had is, would you offer surgery for this patient? And what are your indications for surgery in a patient with bilateral genu-varum and someone who's healthy and doesn't have any symptoms?
So we've picked on the second years and the chiefs. Are there some third year residents?
Third years. One third year. Someone has been working over here, so yeah. Hi, Kat. Where are the other third year hiding? I see the third years.
So you've given some information. What's your next step?
I would measure the various malalignments, which I guess we've already done, and it's up there. What was the leg length? I would see how they do with like just a shoe lift as well.
There's no leg length discrepancy. Okay. It's half a centimeter. It's physiologic.
So much of the time we get mesmerized by studies and measurements and things like that. It all comes back to what is the patient's chief complaint. So let's go back to the first page. So what is this? No pain, no discomfort. It really, in his mind, it's cosmetic, correct?
Yep.
Is this a variant of Blount's, do you think? Or is this just Genuvarum?
I mean, he's a little older. I think maybe it could be because it's persisted.
So this begs the question, you can see the mechanical axis obviously involving the medial compartment, but there's probably millions of people, and my x-rays probably actually look worse than those. But nonetheless, I'm not having any pain or symptoms. So I think it's so tempting to treat an x-ray. And I think at the end of the day, talking to your patients is the bottom line. So personally, in this particular case, I would just watch and follow.
Do you ever have the discussion of, we talk a lot in peds about prophylactic surgeries. You can think of like hip surgery for developmental dysplasia as a prophylactic procedure to prevent arthritis in the future. There's some evidence from, I think like 2010, Sharma did a big multi-center study and with thousands of patients and showed that the odds ratio of developing medial compartment arthritis with 2 degrees of varus was 4 compared to the people without varus. Do you ever like invoke that as
that does come into discussion, absolutely. But boy, it's hard to bite the bullet and perform a procedure on a patient who's symptom-free.
That's right.
Hey, Kevin, I'm going to ask one of our newest colleagues here, Dr. Jackie Hill over here. Jackie is our new pediatric orthopedic surgeon. Actually have an expert in deformity over there. So, Jackie, what do you think? So you probably get tons of these consults all the time from anxious parents. I just tell them that, my partner Drew Lansdowne runs pretty fast over there, with this deformity, with this good. So what do you think? Yeah.
Yeah, so I usually have a similar conversation to what Dr. Garcia is saying about potential for future arthritis, but that it's not an emergency and we don't know 100%. But just to give them lots of information, try and make it a shared decision-making process, because oftentimes they're coming, I think, wanting something. And so just to say, how big of a surgery it is, what that recovery is going to be like, the potential benefit for it is that we think it might prevent arthritis in the future.
And when you have that discussion, how many of them sign up for a procedure?
Probably 50-50. Yeah. I think there, as you know, there are some people who are coming looking for surgery. So if you offer them that, they're probably going to choose it. But there are some people who hear a large procedure and what that recovery is like and the potential risks and benefits of doing an opening wedge osteotomy to correct this. And they'll say, no, thank you.
Yeah, great points. So since we're discussing this, we offered surgery. But do you have any thoughts on if you would do both at the same time versus one at a time, which side you would start with? And then kind of the things we talked about a little bit earlier, but gradual versus acute. I could probably guess which one you would go for there. But and then what is the ideal alignment in this patient who's otherwise symptom-free?
So it's tempting, obviously, if they're having symptoms in the medial compartment, we would follow Fujisawa's line and shift it over to the lateral side by, I think it's 64% or something like that. If they're not symptomatic on both, I'd probably just do one at a time. But we did publish a paper in 1997 in the Posner paper where we looked at circular external fixation, and we found that to be really effective. I'm not so sure we would necessarily do that in this particular case. From the standpoint, A, they're not symptomatic. If you're trying to do something prophylactically, I think you have better control by doing it gradually than doing an acute correction.
Yeah. Great.
Hey, Stephen, I'm actually had Dr. Diaz over here, our arthroplasty surgeon. He has a question about how do these deformity affect, the patients down the road, years down the road for him. Yeah.
No, my question, guys, is I think this is the right place to make you guys. This question is, we always discuss with my partners which is the proper position to have the scanogram. It is with the patella facing the mid part of the femur, is with the foot wide apart, is it with the ankles. What do you think? Because we have found different techniques, and actually the most important thing is you have to have a reproducible view to check your results afterwards.
Yeah, in my experience, we've done patella forward every time, but the reproducibility, I guess, is hard if you're not doing it in your facility for every single X-ray. I don't know if Sue had thoughts.
No, I think that's exactly right. And drawer paley has taught us to make sure that the patella is centered between the two condyles.
Yeah.
That's probably the most reproducible way of doing it.
Yeah.
So what'd you do?
Yeah, so we did exactly what you thought. Started with gradual correction on the left side with tailor-spatial frame with 2 rings. And this was done in March of 2021. And these are kind of his immediate post-op, first post-op visit alignment. And these are his progression a month later, now in April. And these are some clinical photos as well as his standing scanogram films. You can see the progression from the left to the right. And then the hardware was removed in July, so he had kind of 3 months of this and is now in a little bit of valgus, which is appropriate. Where would you have stopped here?
No, I think that's a good alignment. I think you're not really unloading the joint if you're directly down the center, so just airing a little bit on the lateral side makes sense. So what went into the discussion about doing both at the same time or one at a time? After going through this procedure, was the patient excited about having the other one done or not?
My gathering, well, Dr. Savarwal can help, but my gathering from the notes is that they were not excited about having another gradual correction.
Yeah. Well, right, exactly. And just to, not to be defensive about it, but he kept coming back and he did have some symptoms. And I tell you, and, I'd be interested to see what Kevin's thought is and others. Body habitus also matters, right? If you have a large thigh girth person, they're going to tolerate varus a little better and valgus a little less well compared to somebody who's thin and has bow legs. I mean, what's your thought? I mean, we talked so much about proms. This is patient. He's having an issue with his legs. And we briefly just talked about it earlier. Is this a treatment or is this an enhancement?
So it's a little bit of both. I think you did an excellent job, Sanjeev, and you bring a good point because this fella, he has toothpicks for legs, and so any degree of varus or valgus will be very obvious. Did you talk to him about, does he have any body dysmorphism issues?
No, I mean, I didn't have the luxury of having a psychological sort of evaluation, but you could just see it. He's bothered by it, and he was focused. I think he was a soccer player, and he said, it was soft, but it's like, after I play soccer, it does hurt. And, just the stuff we talked about, his MAD was barely touching, the medial plateau. So I think on a bad day, I said, let's do it.
No. You don't have to defend yourself. But once again, you did the osteotomy subtibial tubercle. Once again, not to disturb the mechanics of the patellofemoral joint.
Exactly.
So then thoughts on how would you offer the same surgery, or you talk to them about acute versus gradual if they really hated the frame?
I think we can be so accurate with gradual distraction osteogenesis because there may be some other subtleties looking at the posterior slope. And one of the things I've seen in the sports world when you're doing an opening wedge osteotomy for varus, that you not only change it in the coronal plane, but you're also changing it in the sagittal plane. Mm-hmm. I've seen a number of x-rays where because of the osteotomy and implant, you actually increase the posterior slope, which opens up a whole new other can of problems.
Yeah. And
Kevin, I have a quick question. We've seen 2 proximal tibial osteotomies with corrections with hexapod frames, and you've mentioned this idea of going infratubercular to avoid affecting knee biomechanics. What is that magic number? What is a overly aggressive HTO above the? I mean, do you go below with a frame on every case, or are there more subtle degrees of correction that you think are still amenable to kind of a conventional HTO?
Well, that's a good question. I always worry about obviously increasing the joint load going above, particularly in the patellofemoral joint. So personally, when I'm using gradual distraction osteogenesis, I'm always going subtubercle.
Yeah.
Sanjeev and Jacqueline do the same, or are you going above the tubercle?
Mostly below for gradual, but for acute, I think I do the biplanar thing, and above the tubercle, unless there's any issue with patellar height, Baha or Alta.
To talk a little bit of a different procedure, for the other side, Dr. Zabrawal did a biplanar opening wedge osteotomy with plate and then structural allograft as well. I think we're probably running out of time, so I'm going to keep moving. And just get to his final alignment films. He had similar correction on both sides. And I think it looks really nice with both procedures being done in the same patient.
So now he's 4'8" and he wants cosmetic lengthening, right?
It's very insightful. I asked him, because this is a case control, I said, which side do you like first? Which did you like more? So he was like, and he was very astute. He's like, I actually hated the journey for the first side, but now I like that side better than the other side. And I sort of thought about it, and I think the only thing I did differently was a little bit of translation, laterally on that gradual side. And I think that makes it a little different. We look particularly at his post-op clinical picture. Now, maybe, and again, we're talking here, but perhaps that does affect the overall alignment that people talk about, of the tibia.
And can you go to the lateral of the osteotomy side? So I'm looking at the posterior slope, and I can't really tell from here, but do you think it matches the distraction side?
Yeah, I think it was pretty close. And both were, increased slope, so we kind of, jacked it up a little bit more.
Got it. Well done, Sanjeev. Well done.
He wasn't happy right after the fixator came off. He really wasn't happy. It was over time. And I think that's not an uncommon thing, that something happens to memory and they're like, I actually, I forgot some of the pain that was associated with the initial part.
Great. Oh, one more.
With Dr. Dang over here, was another one of our alumni that's going to share some thoughts. Yeah.
Hi, I was wondering if he's back to all the sports that he was playing before.
It looked like it from the notes, yeah. Exactly.
Okay. Okay, good.
Great, thank you.
Good morning. My name's Sergio Flores. I'm going to be giving a case presentation on an ACL revision. I only have 10 minutes, so we'll move quickly. So this is a 32-year-old healthy man who had a right knee pain and instability. He had a history of ACL reconstruction with a hamstring autograft 6 years ago. Post-operatively, within 2 weeks, he developed an acute coag-negative staph infection. He underwent an IND. They retained the graft, and then he had a total of 3 months of antibiotic treatment. 2 years later, his tibial screw backed out. He underwent an IND and screw removal, and then post-op had a wound dehiscence that was closed and had no further wound healing issues. And then fast forwarding 6 years to the current time, he now represents after he re-injured his right knee playing basketball. He notes pain and instability. On exam, his range of motion was -3 to 140 bilaterally. He had a 2B Lockman, positive pivot, stable collateral, negative dial, and he was tender at the medial joint line, and his incisions were well healed. So here are his radiographs. As you can see, he also had a left ACL reconstruction with the BTB autograft that was asymptomatic. On his right, you can see his tunnel positions. There, it measured about in the 31%, and then his femoral tunnel placement was appropriate. He had 4 degrees of posterior tibial slope, and his tunnels measured 11 millimeters on the femur and tibia. These are his standing alignment films that were neutral. Here's his MRI. So he has a tibial cyst there. And it appears to be an attenuated graft. Then we'll show the coronal. You also note he has evidence of a medial meniscus tear, and it looks diminutive and slightly extruded as well. So Dr. Wright, this is a failed autograft hamstring reconstruction. He also had a previous infection. Currently has normal ESR CRP, no signs of infection, neutral alignment. What would be your next steps and what would you consider for this 32-year-old?
How old is he now?
He's currently 32.
Currently 32?
Yes.
Yeah. Obviously wants to stay active and is having instability and is not satisfied with his
No, he's not
lifestyle.
satisfied. Yeah, he likes to play basketball.
Yeah. Because when you talk to these people, you have to avoid instability, either by replacing the ACL or by changing your lifestyle. And it's a lifestyle decision. I tell every patient that I have with an ACL tear that if I tore mine, of course, I'm older, and I look at my lifestyle, I do body weight kind of exercises and a Stairmaster and a treadmill. I don't think I need an ACL, so I probably, just to avoid the hassle of rehabbing it, would probably see if I had future instability. So it's a lifestyle decision. So how worried are you about the previous issues they had with the wound and the potential infection? And there was some fluid signal on the MRI on the tibia. You got the ESR and CRP, which I think is smart. How concerned are you about that there's a quiescent? So if you had Dan Flanagan, he's sitting here from Ohio State, he would tell you that a lot of our revisions are the result of some low-grade infection that we just can't ever pick up on.
Yeah, I'd be concerned about it and definitely would want to make sure he currently doesn't have an infection. So, that would consider in my treatment plan, I'd consider an aspiration of the knee or even.
You think aspiration's going to be positive?
No.
No. Otherwise, you'd have acute signs of if it's an intra-articular infection like that, I think you'd know it. So I think you either bite the bullet and ignore it, unless you see something at the time of surgery, or you go in, drill the tunnels that you think you're going to use, debride it, get rid of all the old hardware and graft, and stop and come back 6-8 weeks later when and see how they recover from that. But that's pretty conservative, but it's a little worrisome from the previous events. Mm-hmm. What do you think about the medial meniscus?
So it did look diminutive there. It measured, well, I wouldn't want to spoil anything, but it measured about 4 millimeters of a rim left. And so I would have that discussion about potentially addressing that at the time of revision ACL.
Are they having medial symptoms?
They'd had joint line tenderness, but it sounded like mostly their symptoms were of instability.
Yeah, did not to me look like a repairable meniscus. So are you going to do meniscal allograft in what probably after you debride it will be an asymptomatic medial meniscus going forward? Do you think their activity level is going to warrant that, or are you going to debride it, sit on them, and revise the ACL and see how they do?
Yeah, I think that was a question we were going to ask as a discussion point of when you would consider a meniscus transplant. I think, we can keep going.
Yeah, why do you worry about the medial meniscus in this setting?
So in a setting of an ACL deficient knee, it becomes the secondary stabilizer. So if you have a insufficient meniscus, then you could continue to have instability and continue to have medial compartment damage over time.
So as you're saying, losing the medial meniscus, which acts as a chock block, if you're trying to simplify things like I do, for the tibia on the femur, you get increased stress on your graft, theoretically. And everyone loves to, so I can tell you, because I got 1,200 revision ACLs that we have data on, a ton of medial meniscus tears. Everyone loves to stand at the podium and talk about doing a meniscal allograft for this situation, but very few people in the Mars group bit the bullet and actually did it. And that may be to the patient's detriment. So in the revision setting, having lost a medial meniscus, we probably should be much more aggressive than we are in doing an allograft. If you're going to do it, you probably help the patient by doing it in one setting. So I think that very much you need to give thought to that, and unless you get in there and you retain more than half your medial meniscus, which looking at that MRI, too chewed up. So what'd you do?
I'm going to ask Dr. Crickbaum over here, which is Chief of Sports over at the Kaiser, San Francisco. Henry, what would you do in your practice over there? Like, what's your discussion about transplant and no transplant, and also, like, are there any activity modification afterwards when you let them go back? Yeah.
I think it's just trying to figure out what his goals are. I think if, as Dr. Wright said, you can live without your, and for this gentleman, I'd try to rehab. And if he's not able to do what he wants to do and he's still having instability issues, then you can talk about the big surgery and sure he doesn't have a persistent infection, et cetera. But post-operatively, if you do all this surgery and you don't tell him, well, you can't go back and do it, the whole point of this is to get them out to doing what they want to do. So you shouldn't modify goals post-operatively based on what you do, because then what's the point of doing the surgery? Maybe that's a simplistic way to look at it, but that's primarily why people come in to have elective surgeries, is to increase their function, at least in my practice. So that's kind of the way I look at it.
So he ended up going to the OR for a diagnostic arthroscopy and to get cultures taken. At the time, there's no signs of infection. He did have this torn ACL graft, and they ended up bone grafting the tunnels. They measured about 11, but used Kinsella's chips. And this is a picture of the medial meniscus, which you can see is diminutive and torn. So in terms of post-op, here's his bone graft that incorporated. For the next step for treatment plan, what would you choose for your graft choice? Any associated procedures you would perform? We talked about meniscus transplant, and when would you consider it? Like, do you have a cutoff in terms of millimeters of meniscus remaining, or how do you decide that?
I think it's always a little harder to tell how much meniscus you think you took and what you took, but you always typically take a little more than you think, or you lose a little more than you think. So if I felt comfortable that the person had lost half their meniscus, then I think it's time to at least have a discussion with them about the risk, protective biomechanical effect. But I think we have to remember that when you get a meniscal allograft, it's going to be hard to do basketball, soccer, any kind of really rigorous cut, turn, twist, jump, change direction sports. You just don't see college or professional athletes coming back with meniscal allografts very much. And not that he's a collegiate athlete, but he would have to probably restrict himself to more cardiovascular exercise type, but have the discussion of a meniscal allograft. And I would, having had a previous hamstring, I would come back with a patellar tendon autograft.
Just in the interest of time, I think we're pretty much out, but here are his intraop images of his healed bone graft and meniscus. This is the femoral tunnel, the tibial tunnel. And then here's a video of performing the meniscus transplant. It was done through a transtibial drilling and then all inside repair of the periphery. And they did use a patellar tendon autograft as well. So post-operatively, he did well and is back to all his activities by 1 year.
Yep, looks good.
That's what he wanted to do.
Based on the notes, yeah, it sounded like he got back to most of his activities that he was doing prior.
I mean, this is maybe I'm being too critical, but if your goal was just to run, I would say reassess your goal of doing the surgery. It's a lot to put someone through just to potentially run. And now if he's having instability with everyday activities, then probably a different discussion. But I don't know, if running
He was having daily instability and pain and was really unhappy and not able to do much of anything. And then he was like very thoughtful in the whole thing, and he had been rehabbing for a while, clearly shown that it wasn't working. Yeah, he was very happy by the end of it. So I totally agree that just because he tore, just because his meniscus is deficient, he does not need all of this. But for him specifically, it seemed to give him a lot of benefit.
Like it or not, there's a stair level of decrease in activity, and the residents don't really want to hear it, but it's at 18. A lot of people play high school sports, and they do a little bit in college, not so much. If you do a lot in college, then at 22, you take another downgrade. If you look at Mark's activity scales, that's what happens. 22, you get a job because you get out of college. Hopefully, you get your kids out of college by 22, Ben. But 22, 3, 4 on the 5-6 year plan. Then somewhere between 26 and early 30s, a lot of people end up settling down and getting married. Activity really drops again. Then you have kids, and then all you're doing is driving them around, and it really drops again. So, I love it when this, when a 30-something says, well, I'm engaged to be married, but I'm still going to play men's soccer league 3 nights a week. I go, I don't know. You're going to have a lot going on, a lot more going on. So anyway, good cases.